pleasure to be here with you today. Thank you for taking the time out of your busy schedule to chat with me. I've spent some time reading and really researching your professional accomplishments and all the work that you've done in the space of behavioral health. But I'm sure I just scratched the surface. You have a very accomplished and impressive resume. You've received a lot of awards and accolades. But now that I have you in front of me, I just want to give you the opportunity right now to tell me a little bit about yourself.
Well, first of all, thank you so much for allowing me to do this interview. Well, I'm just a country boy. Not quite country. I actually grew up in Florida, military family. Grew up in Central Florida in the 70s and have spent my career now as a psychologist, working primarily in public policy, working in the state of Connecticut and then in the city of Philadelphia and now at the American Psychological Association. So I really see myself as a servant leader and someone who has dedicated their lives to trying to make other people's lives better.
Under your leadership at the APA, you recently released the results of stress in America. And it shouldn't come as too much as a surprise when it says that we've got a lot of stress. And I know individually, I probably made up a lot of that data. But the report made a very eloquent argument that the United States is facing a syndemic. Would you tell me a little bit about that?
Yeah, what a syndemic means is that, in addition to all of the things that you would see in a pandemic, that because there are these pre-existing conditions, particularly in terms of health disparities, that they actually interact and exacerbate the other conditions that we have occurring because of the virus and the viral pandemic that we're also dealing with. So, it's not just the impact of the pandemic, but it's these pre-existing conditions that exacerbate that and make our dealing with these issues much more complicated.
And I know that's a major deal for the African American communities because we have a lot of underlying issues that even prior to the pandemic that we have to deal with on a daily basis. You've also,
and if I could just say this,
yes, sir.
That's very true. And when we look at it as the American Psychological Association, we're looking at not only the physical health issues, but we're looking at the mental health issue. One of the things that complicates this pandemic is the behavioral health or the stress, the psychological distress that people are experiencing, and how that also interacts with the pandemic that we have around the virus. And so really understanding the interplay between these different conditions is really important in terms of our understanding of how we need to help people.
And I know that you've also written about a subject that's very much on everybody's minds today. And that's just how all of these vaccines going to really get into the shoulders of African Americans, because we know that African Americans have very, very limited access sometimes to mental health and behavioral health treatment. So this is for a population that faces a lot of obstacles and have high levels of what experts keep calling vaccine reluctancy. What are some of the forces behind resistance when it comes to the African Americans community?
Well, I think as you're pointing out, there are multiple issues. There are longstanding issues around access to healthcare and healthcare services that are at play here. But then there's also the vaccine reluctancy or vaccine hesitancy that you talked about, which really has to do with the African American community's view about the vaccine and whether they want to take it. The reason that we have that is because of longstanding issues with the healthcare system. It is no secret that the healthcare system has not been good to African Americans in many instances. Many people talk about Tuskegee and the Tuskegee study, the syphilis study, where African American men were intentionally injected with syphilis to study them and not given the care that they need. That looms large in the minds of many people in terms of the trust or the mistrust that African Americans have. But more contemporarily, it's not just that those historical things that have happened like Tuskegee, but it's the contemporary things that we understand. We know, for example, that when we do experiments and we provide clinicians with two identical clinical presentations, say cardiovascular disease.
Mhm.
We ask those clinicians to identify their treatment plans, that they are different based on race. If you
Mm.
just change one variable, the race, people come up with different treatment plans, which are often less aggressive for African Americans. And we know from other data, we know that African Americans receive state-of-the-art treatments at a slower rate than other groups. We know that there is interpersonal and unconscious bias, or what we call implicit bias, that is at play. So there are all of these other factors that impact on people's trust of the healthcare system that are at play. And then with the vaccine in particular, where you've had the unfortunate politicization of the pandemic, there is mistrust because of that politicization and some of the political leaders who have talked about the vaccine, but whom the African American community doesn't have a lot of trust. So there are a lot of issues here that we have to overcome. Our position at the APA is that we want people to have the best information and to make the best decisions, the best healthcare decisions, and for them to have access for the vaccines. And we hope that if that happens, that more and more of the African American community will, in fact, take the vaccine, because we are dying at a much higher rate. This is having a much greater impact on our community. And therefore, it's really important, especially important for our community, to take advantage of the treatments and the vaccines that are available.
So thank you so kindly for that last comment, Dr. Evans. We were talking about how the reluctance African Americans are to get the actual COVID-19 vaccine, excuse me. And so who and what seem the best way of addressing this vaccine reluctance in this pandemic?
Well, I think we have to be willing to use multiple strategies, because the African American community is not a monolith. There are all kinds of people, attitudes, and reasons why people may be hesitant and reluctant. The most important thing is that I think we have to stay engaged. I think we have to start with um, working with people in the community, particularly leaders in the community, and a variety of leaders. I think most people understand that it's important to work with church leaders, but it's also important to work with leaders who are not a part of churches, because there's a segment of the population that is not necessarily attended to or connected to a church. In Philadelphia, where I lived for 12 years, it's very important to talk to the imams, because there is a very large Muslim population. So I think people have to have a real understanding of the community, understand where the leaders are, and to work with those leaders. But it's also, we have to address the issue around how we distribute resources differently also. I talk a lot about the issue of psychological access, that it's not always just where things are physically, but it's also where things are, and are they in a place and accessible in a place that people feel psychologically is a place that they feel comfortable in. So I think it's all of those kinds of factors that we need to put into our strategy. And I think if we do that, we're going to be successful.
And what role do you see, if any, that the behavioral health community providers can potentially play in that?
Well, I think behavioral health providers are going to be very important. One, because for many people, they have longstanding relationships with members of the behavioral health community, behavioral health professionals. Behavioral health professionals understand a lot of the dynamics related to human behavior, and which need to be taken into consideration, particularly understanding communities and sub-communities. Again, with the last community that I lived in, you have to know the difference between the communities in West Philadelphia and the communities in North Philadelphia. You have a large number of immigrant community, a large number of immigrants in some communities, and which countries are those immigrants from? Those are things that people in the behavioral health community understand well, because they're working with these communities, and bringing that knowledge into the strategies, I think, is going to be very important.
Yes, sir. Thank you. And I think one of the major things that you did state also is being able to not just look at this thing that all African Americans are the same, and just understanding from community to community and from area to area that there are some differences, and we have to be very mindful of that. So thank you. Also, in your Stress in America report, you talked about some of the projected long-term effects of what we're going through now and in the past year, including some of the particular stresses that young people are carrying in the behavioral health field, especially in African American communities. What should we be preparing ourselves for in the future?
Well, if you look at what's happening now, there are a number of things that are happening now that we know are going to have longer term impact. The level of stress that we're seeing in terms of the nation, the level of symptomatology, and all that means is that there are a lot of people who are experiencing symptoms that are consistent with having mental health challenges, disturbances in people's sleep, disturbances in eating, feelings of anxiety. That when you ask the population, what we're seeing is that that level of symptomatology is sometimes 2, 3, and in some cases as high as 4 times what it was before the pandemic. And we know that when people have long-term stress, long-term psychological distress, that for some portion of the population, that's going to turn into both physical health problems and mental health problems. So one thing that we can expect, given what we're seeing in all of the data that's out there, is that there are going to be higher mental health needs, and there are going to be higher physical health needs as a result of the stress and stressors that people are under. We also know for children that there are a lot of disruptions in their in normal developmental milestones that they might be experiencing if they were in school. Those are going to have some impact. We don't know what the impact is quite going to be, but we know that it's going to have some impact. And I think we have to be prepared for that. I think given that, though, I think it's also important to remember that people are pretty resilient. And that for the most part, we're going to be able to bounce back, that people are going to do well. But similar to what we understand from trauma, one of the things we understand from trauma is that you're going to have 100 people, expose them to the same trauma. Most people will bounce back, but some people are going to develop post-traumatic stress or some condition related to post-traumatic stress. Well, why is that? Sometimes it's because of their particular exposed to the trauma. Sometimes it's what's happened post the traumatic event and what kind of support people get. We don't know it precisely why people develop problems, but we do know that because of those vulnerabilities and those differences, that some people will. That's what we have to be aware of, and that's what have to be prepared to deal with.
Yes, sir. Thank you so kindly. I know that this pandemic, at least the COVID-19 part of it, is practically forcing us to learn just a little bit about public health, a subject that you've been very passionate about for decades. But our nation is really struggling to understand and follow this. Why is this so hard?
Well, I think for people who are in the healthcare arena, it's because of the way we were trained. We were trained to look at healthcare through the lens of the individual. So you're trained to diagnose a person. You're trained to work with an individual. Furthermore, we have, particularly in Western cultures, a really strong biomedical focus. We are very reductionist. So we try to explain everything at the genetic level or the biological level. And one of the characteristics of good science is that it's parsimonious, that we use the simplest explanations to understand phenomena. And often those explanations are at the community level or they're at the family level. And so fundamentally, one of the things that we have to do in our field is to embrace understanding healthcare and health at a different level of analysis, not just the individual level, but at the family level, at the community level, at the societal level, because the reality is that it's at all of those levels that we have to intervene. One example, for example, we know for working with children, one-on-one therapy can be helpful, But for particularly young children, family therapy is much more impactful. Why? Because children operate in a family system that supports them, that really shapes their experiences and their behaviors, and that if you really want to help children, you have to do it in the context of the family. That's one example. Another is, what we're seeing with the stress during the pandemic. It is widespread, and there is no way we can treat our way out of the level of stress and distress that people are experiencing. We're going to have to use other strategies. Yes, treatment is important, but we also ought to be using strategies that provide education around things that people can do themselves to reduce their stress levels. There are things that we can do to mitigate the level of stress that people are experiencing. For example, the American Psychological Association is spending quite a bit of time talking to leaders, to CEOs, to principals, and to superintendents, because they can make decisions that can reduce the level of stress of the constituents that they have responsibility for. So that's what a public health strategy is. It's not only thinking about the individual, it's thinking about the broader public. It's thinking about these issues at another level of analysis, and then being willing to intervene at those other levels, whether it's the community level, the societal level, the family level, or the individual level.
I know at this new African American Behavior Center of Excellence that I'm charged with leading, we want to help. We really do want to help. And how can we take advantage of our fields and our nation budding awareness to deepen people's understanding of population health concepts and apply them to the work that we do in behavioral health? Because I really do think that that's part of our charge.
Yeah, I think we have to demonstrate why this perspective is so important. And I'll give you a couple of the examples of that. One of the major challenges with mental health in the African American community is that there is a lot of stigma associated with having a mental health challenge. What I used to say when I was commissioner is, it doesn't matter how great your program is if people are not willing to come because they're embarrassed or they're ashamed. So we have to, as a field, not only make sure that people get good, excellent care and that our clinicians are trained and that we're using the best practices, but we also have to work at the community level and with communities to actually reduce the stigma, the stress, to normalize mental health issues. And when we work in tandem like that, that's when we have the most powerful effect, because people are much more willing to talk about these issues. They're much more willing to reach out for help. And then when they reach out for that help, they're getting the best possible care. So that's the message that I think we have to make. That's the argument that we have to make. And that's really the compelling reason why we have to think about these issues at a systemic level and be willing to make the policy changes and the system changes that are actually going to move the dial and make sure that we're getting the kind of care that we need in our communities.
So it's going to be a really major collective approach from all of us, from a systems level down to the community providers, down to these centers, colleges and universities, in order for us to have a major impact. And to me, it just seems like, and it sounds like, our field is due for some transformational change. I believe that, and I think that. And as you know, first in Connecticut and then in Philadelphia, you've led some major behavioral health system transformation. Of all the lessons you've learned in those experiences, what do you think might be the most important for us to use from the things that you've learned?
I just love this question because I think it's fundamental to our making progress in addressing issues in the African American community. We have to be willing to draw outside of the lines, to color outside of the lines. That's the way I describe it. I mean, when you get trained as a psychologist or social worker or psychiatrist, we start to embrace this identity about what it means to be a psychologist. And what are the interventions that a psychologist does or a psychiatrist? And we limit our interventions, the impact that we can have, to a very narrow set of things that we think fit inside of that box. But the reality is that what people need often go beyond that box. They go beyond the typical ways that we're trained. So, for example, we know that if you take people who are experiencing a mental health challenge, stable housing turns out to be really, really important. But if your identity is, well, what I do, I don't do that. What I do is psychotherapy. What I do is medication. But what people really need is stable housing. Then we are cutting off important interventions that can make a much greater difference. And, in my work, what we saw in some of the work that I did when I was commissioner is that we dramatically reduced the cost, improve the outcomes of people simply by getting them in stable housing. And so if you're looking at the ultimate outcome, which is we want people to be healthy and well, we have to be then prepared to use our science, use our training to identify those things wherever they are, whether they're housing or whether they're education, whether they are things outside of our field, and be able to partner with other people in other areas to make sure that people have those, because ultimately those are the things that we're going to have the biggest impact on people's mental health. So I think that the biggest challenge is we have to change our mindset. We have to go from simply thinking about working with individuals. We have to think about how do we work outside of our training, which means partnering with people outside of our field. It means that we have to be willing to do different interventions. I'll give you another example. One of the things I did in my last position as commissioner was large-scale community art projects. People say, like, why is a commissioner, the mental health commissioner, doing art projects? Well, I wasn't interested in art. I love art, but that's not my job. Other people can do that. What we were doing was we were engaging the community. And the way to engage the community was through these community participatory art projects. I used to say, if we showed up in the community and said, hi, I'm the mental health commissioner, and we're here to help. We'd like to talk to you about mental illness. About 2 people might show up, and we would probably be related to, half of them, right? But we could go into communities partnering with community art groups who are doing murals and engage literally hundreds of people who wanted to participate. And while we had that captive audience, we were doing that artwork around issues like recovery, trauma, other issues that were related. And it gave us an opportunity to talk about these issues and to reduce the stigma around them. So, that's an example. It's our willingness to get outside of our comfort zone, to partner with people, but be clear about why we're doing it. And in that case, it was about reducing stigma. And in fact, we had done some research, with some colleagues at Yale who looked at the impact of doing that work in the community. And people had a greater sense of psychological sense of community who participated in those projects. So, it's that kind of out of the box thinking that we have to do. It's going to be different for very different communities. My family is from Alabama, and rural Alabama is very different from New Haven, Connecticut, or Philadelphia or LA or Detroit. And so understanding that community and being willing to do what's going to work in that community, I think, is really important.
And I think with those examples, you really demonstrated how we can build trust in the communities as well. I think while we're decreasing the stigma, we're also building up that level of trust. And you answered my question, because my next question was, how do we shift our thinking? And so that was definitely right on point. And for years, that African Americans have been disproportionately serviced across many sectors and not providing access to care. What do you think needs to happen for a sustainable shift to occur?
We have to work at the policy level. It's great when we develop new interventions. It's great when we develop a new treatment. It's great when we develop a new medication. But if you look at the inequities that you see in communities, it's not because of those treatments per se or lack of those treatments. It's the structural issues that give people access to those resources. When I was in Philadelphia, we did a study that showed that African Americans were accessing treatment at a lower rate. And typically what we think about is, well, maybe we need to do more cultural competency training. But when a researcher from the University of Pennsylvania really looked at it and geo-mapped where people lived and where the treatment programs were, what it turned out to be, or one of the biggest explanations for that difference in access to treatment, had to do with where the treatment programs were. No amount of training of clinicians, no amount of treatment is going to change that. You have to change the resource allocation, and that can only be done at the policy level. And so I think that if we're going to sustain our efforts, we have to understand, what are the major policy issues that we have to take on. The allocation of resources is one of them, but it's also the flexibility and spending the dollars in ways that make sense for different communities. One of the biggest challenges we have is that so much of our dollars in the mental health system are tied up into fee-for-service services for a specific diagnosis. I gave you an example a little while ago of work that we were doing in a community that was literally engaging hundreds of people. They didn't have a diagnosis. But that work was really critical. And so if we want our people to be able to, the people who have responsibility for systems to do the work that's necessary, they have to have flexible funding that allows them the creativity to do the work that will make the most sense for those communities. So that's policy work, and that's what it's going to take in order for us to sustain our efforts.
And we're very thankful and blessed to have you as part of our advisory board for the Center of Excellence. And so as we're continuing, it's a 5-year grant, and as we're continuing our work and our efforts, how do you think that we can really contribute to having sustainable care and sustainable change for people?
Well, I think that it's about, frameworks. One of the things that I've learned that is the most powerful in doing transformational work is, how do you think about an issue? If you think about an issue as being biological and individual, well, that's going to limit your options. And so one of the things that the center can do is to really help people to have a different frame, a different understanding, number one. And I believe that's a population frame. So we're not just working with people after they have a diagnosis, but we're thinking about the entire population. For those who are well, how do we keep them well? We don't do much of that in our field. We do that in physical health. We talk about exercise, we talk about eating right, but we don't really talk about, here are the things you need to do to stay psychologically healthy. It means for people who are sort of in that middle group between having an illness and being well, the people who are at risk, it means how do we help to reduce and mitigate the known factors that are related to mental illness? Or if we can't do that, an example of that was, can we reduce people's exposure to trauma? Because if we know if we do that, we can reduce the likelihood that they're going to develop mental health problems. But there are a lot of things that we can do in our community that if we were to reduce those things, it would lead to less mental health issues. We need to be doing that, but we also need to be educating people so that for that middle group that's at higher risk, can we get them connected to treatment much earlier? That's why the community education kinds of strategies are so important. So that's a whole population approach. We're not just waiting until people are in crisis. We're trying to get to people, what we call upstream, earlier in the process. So I think if we can do that, if you can help to promulgate that way of thinking about it, to develop maybe model policies, to talk about what are the things that we know, what are the places that have been quite successful at reaching the African American community and being successful in treating the African American community. Those are the kinds of things that we need. We need people who can really help the field understand these issues, give people ideas and resources to do the work in their own communities.
I really appreciate this, Dr. Evans. We've had a great time chatting today. You've given us a lot of information, but it just demonstrates the breadth of all of your experience, and it's hard and how passionate you are about this. And so again, I'm very fortunate to have have the opportunity to chat with you today, but also to have some opportunity to continue to dialogue with you around these issues. And definitely, on our being a part of our board, but I do want to see sustainable change. And it's people and pioneers like you who've led the way in the charge of doing this work that we're so appreciative of and grateful. So thank you for taking the time today to chat with us. And I think that'll wrap it up for us. Thank you.
Thank you. And I appreciate this. I am so excited about this work and what you're doing and what the center is doing. I know we're going to make a difference. So I'm just grateful to be a part of it in any way that I can be. So thank you so much.
Thank you. Have a great day.